and he advocates, he is very vocal in the the issues. And second speaker would be Karori Singh. Professor Karori Singh is an emeritus fellow, University of Rajasthan. He was the former director of Center for South Asian Studies. He will follow Dr. Nihal Labesinghe. Then we have Dr. Nishal Pandey. He is the director director of the Center for South Asian Studies, Kathmandu, Nepal. And the fourth speaker is Professor Muniz Ahmed, emeritus, the professorial professor of international relations, University of Karachi. First of all, I would like to thank all these four panelists and also participants because they will take each speaker will take about 15 minutes. The most important thing is the panel discussion. We will have 1 hour to have the discussion. Therefore, without ado, I would like to invite Dr. Nihal Labesinghe to present his views. Dr. Nihal Labesinghe, floor is yours.
Thank you, Professor Kiravella, and thank you for invitation. Could you kindly provide me the share screen facility?
Nimni?
Professor, I will.
Thank you. Let me start. Okay. Okay. Thank you again for inviting me to join this webinar. In fact, I was working for the Ministry of Health for 27 years in the country, and I left for WHO regional office in New Delhi in 2008, and I was there for 8 years and returned to the country back in 2016. Now currently I am working with the Institute for Research and Development and also the president of the College of Community Physicians of Sri Lanka. So I think public health is my my career for almost 38 years now. So I think I should be able to do the justice for this topic. So basically the topic given is the COVID-19 pandemic and public health system in Southeast Asia and meeting the unprecedented challenge. So I will be talking to you on the Sri Lankan situation, and I would briefly share you that the characteristics of a good health system, and then the Sri Lankan public health system, its achievements, magnitude of the pandemic Sri Lanka is facing now, and what functions were more important in facing the pandemic and the lessons learned so far. So, so these are really if I utilize this slide of one of my colleagues, that any health system to be functional and effective, it has to be based on scientific evidence. Priority for it should be a priority for politics, economy, and society. Well organized with regard to goals and its key functions. In service delivery, it should have promotion, prevention, curative, rehabilitation, and palliative services. And it has to be universally accessible and easy navigation and less risky to the public and the users, and from health and financial points of view, and responsive, sustainable, and supported by other systems. It's multi-sectoral coordination at policy level, then the primary, secondary, tertiary levels in the health system. So basically, I believe that Sri Lankan system, generally we had a very good system up to about 2000, and then it started confronting issues from 2000 to 2020 because of the economic changes in the country. Sri Lanka embarked on this open economy, neoliberalism since early 80s. So, I mean, all the issues that we faced after the 2000 and before 2000, we have achieved a lot in the previous settings. So it is, I mean, we do have a good system. We started with a good system when we were facing this epidemic. But if you look at what WHO says in their report in 2000, that the way health systems are designed, managed, and financed affects people's lives and livelihoods. Difference between a well-performed health system and one that is failing can be measured in death, disability, impoverishment, humiliation, and despair. So poorly structured, badly led, inefficiently organized, inadequately funded health system can do more harm than good. Ultimate responsibility for the performance of a country's health system lies with the government. So that is what we see now. I mean, if the government can really run the health system smoothly in any crisis situation, then we can see the results. But otherwise, we see its consequences. So the careful and responsible management of the well-being of the population, stewardship, is the very essence of good government. The health of people is always a national priority and government responsibility for its continuous and permanent, because there is no way that government can give up the responsibility at any level, whether it has a private sector or public, a public sector separately, or like in Bhutan, only public sector. The government has to take the responsibility for health. So Sri Lankan public health system, we had a very sound national level. We are having a epidemiology unit doing the communicable disease surveillance, and we have very well trained public health physicians there, and we have a health promotion bureau and various campaigns for malaria, tuberculosis, STD/AIDS, and like that. And we have a family health bureau where maternal and child health is looked after. So these are the apex body in the public health system in Sri Lanka. We used to give advice, the guidance, and the knowledge to the rest of the health system in the provincial, district, and the local level. So we have a provincial system and a district levels, 25 districts at the country, and the 9 provinces. And the divisional level, we have a public health person called medical officer of health, looking after all the public health activities at the divisional level. When I joined the Sri Lankan health system, public health services in 1983, we had only 106 health units, but divisions. Now we have 352 health units. And at the grassroots levels is the most important level in Sri Lankan public health system. We have one public health midwife. I mean, we call public health midwife. She has 3,000 population, and we have about 10,000 to 20,000 population for public health inspector, so that he looks after the communicable disease surveillance, sanitation, food safety, and related issues. And the public health midwives look after the maternal and child health services. So our grassroots level is the richest level, because that we manage everything at the grassroots level. We do have population registers, we do have immunization registers, we have birth and immunization registers, we conduct clinics, and our people know that when to come to the clinic, and the messages are given by these public health officials. So we had a very sound system, developed over the years, started from 1926 during the colonial era. So our development of the healthcare system during colonial and the post-colonial era, up to about 2000, actually, we had a very good system all the way develop throughout. And then we really don't have basically major infectious disease. Now we have control. We are only dealing with dengue fever and perhaps seasonal influenza and leptospirosis here and there, and it is also seasonal. So beyond that, all the infectious diseases, including malaria and all infected, all all our infectious diseases we have control now. So therefore that we don't have much of infectious disease at the moment, and we have controlled most of the infectious disease. And so in this pandemic, all countries were expected to increase capacity, ensure hospitals have the staff supplies, develop life-saving medical interventions, take all necessary measures to slow further spread and avoid health systems becoming overwhelmed and prevent infection among high-risk persons, including elderly and persons with comorbidities. So the key global strategies were mobilize all sectors and communities to the ownership and participates in the response, and control sporadic cases and clusters and prevent community transmission, suppress community transmission through context-appropriate infection prevention control measures, population-level physical distancing measures, and essential domestic and international travel, and stop all non-essential ones, and reduce mortality by providing appropriate clinical care, ensuring the continuity of essential health and social services, and protecting frontline workers and vulnerable population. This was the motto during this epidemic, what we had to do. Each country had to assess its own risk level and had to adjust to the implementation of these measures. And then, so basically, it was test every suspected case, test every case isolated, and care support for every case, suspect, test and quarantine every contact, and test and retest these contacts, and educate, engage, and empower public on strategies for prevention and control of COVID-19. So epidemic response was, we were expecting to have a systematic gathering of epidemic intelligence data, rapid verification, risk assessment and communications, and coordination of international and national technical support. So it's basically working with the intelligence network, verification, response, and follow-up. So these were the activities expected during the, however, now in Sri Lankan approach, we believed the preparedness was the key. The response between 30th January, where the WHO alerted the whole world about this epidemic and declared this pandemic 11th March. So up to that period, we did not see much of preparations in the country. So this is, I'm looking back and now seeing it. And then there was a cost for the delay in responding, because suddenly between 11th of March and 19th of March, we had to take a decision to a lockdown of the country. And the crisis management would have been multi-sectoral and multi-level, but it was an urgent attention to lockdown situation between 11th to 19th. We managed the initial part of the epidemic, and we had a few clusters in one Navy camp and another rehabilitation center. But basically, we managed the first part of the epidemic with various measures, and we were working to the point, and then we were using our public health system, the public health inspectors, medical officers of health, and the public, the knowledgeable public, to control the epidemic. But we still paid heavy damage to the economy because of the lockdown extended for 2 months. And then we had fairly restricted movements till August, where we had the parliamentary election. And then we relaxed bit till September. end of September. And then suddenly we had an outbreak in, in October. But in this time, we stopped that using our earlier method. And this time we started using isolating smaller geographical areas and introduced limited movement restriction. Schools and universities were closed, weddings and other functions were limited, and then caseload came down to a level to 200 to 250 by March 2021, but it was a very drag outbreak control situation, and we suffered because of that. And then the current surge actually came in the third week of April, and now we are under lockdown or restricted movement since 18th of May. So the strategies were minimizing the movement of people, and then but the people always wanted to know what the government plan, the reasons for taking different measures, and when can Sri Lanka be COVID-free. So the discussions were on, and we were expecting physical distancing, hand washing, wearing a mask, avoid crowded settings. So these were people knew during this phase, but we were not very satisfactory about the situation. So the sound plan, we would have had a sound plan to detect, isolate, test, treat patients, manageable plan for quarantine and protecting staff at the hospitals and laboratories, and engage public to support actions taken to protect communities and ensure smooth running of essential services, making available supplies for affordable price. So we were struggling throughout this second period because we were keeping our economic activities open, and we tried to control the epidemic like Europe and like America and like India. So we were not very successful during this phase. And so we were to know that before releasing our grip control disease transmission plan through existing health system to detect, isolate, test and care for cases, identify high-risk hotspots, develop specific plans for schools and workplaces, minimize the risk of importing infected patients, and ensure basic needs for all, and educate, engage, and empower communities to live under the new normal condition that we were expected people to use the basic measures. So though we tried to get things done during the second phase, I believe that we were not that successful, and that is why we had to face this third phase. So actually the current surge, and now we are having about 2,250, 2,500 cases a day, around 50 deaths report a day. So before the releasing, we would have planned easily and then sensitize our public, the civil society and community leaders, strengthen the surveillance, ensure and hospital facilities, and plan to manage NCDs and antenatal care and immunization. We were doing antenatal care, some NCD care and immunization, but we were not very successful in maintaining the epidemic. So we knew that it was a challenge to the government, and then there were some risks that we had to accept, some risks that we to manage, and some risks to reduce. But we driven by science and evidence approach, and the key to success was trust between the managers, staff, and the public. We knew all this, we had that knowledge, but we could have done better if we minimized the political interference. Actually, our politicians took the upper hand, and then whenever they came to the public appearance in the TV, they started telling what to do about the outbreak. I think we would have avoided that. And we would have trusted the technical leadership. We had a epidemic, we had a communicable disease committee for advising the Ministry of Health, but we did not use it properly for this epidemic. And like America, like Europe, And like many other countries, the politicians involved in the outbreak control, and we really had, we missed our public health system opportunity, in controlling the outbreak to the level that we could have done. And then we tried to do the surveillance, timely action, protection of vulnerable groups, and we failed to a certain extent in achieving what we wanted. And we were to get public trust through spokesperson, but we did not have a technical spokesperson throughout. On and off we had, but we did not have, so we missed that opportunity. And we were to be proactive, but my understanding, we were basically reactive. And so therefore that we miss many opportunities to use our public health system. We had a very strong one. And even when it came vaccines, we were having a good plan and to immunize the elderly and the vulnerable population. But unfortunately, we went to vaccinate masses, and then we missed that opportunity also. So therefore that we are now facing this surge, and we are having a large number of cases and quite a number of deaths at the moment. And actually, if you really look at our public health experience, this is what we gained during the SARS 2002 and 2003. So that means the whole world knew how to face this type of epidemic. But basically, most countries in the world, we fail to really learn from our experience, and we are suffering now. So similarly, Sri Lanka also missed many opportunities, and I think at least now it's time to look back and correct our path. So I will stop here, and perhaps I may ask for questions later. Thank you very much.
Thank you very much. Thank you very much, Dr. Abe Singer. Very informative, candid, and open presentation. Thank you once again, and a lot of things to discuss. And therefore, we will keep that to be raised during the discussion hour. And now I would like to invite Professor Meritorial Professor Karori Singh to make his presentation, focusing mainly Indian situation. Professor Karori Singh.
Good afternoon, friends and colleagues. Professor Gamini Kerewala, Dr. Nihal, Dr. Muniz, Dr. Nishchal. It is a matter of great honor for me to get an opportunity to speak on the platform of one of the high-ranking think tanks in South Asia. With the RCSS, my center has a long association. Even before the establishment of the RCSS, my center has connections and relations with S.U. Kodikara, the founder of the center. So I will not be presenting the dynamics of the system. My task has been made easy by Dr. Nihal, because systems operate almost in the same way in different countries. So I will not be repeating all these things which Dr. Nihal has presented about the dynamics of the system. I will look at things from a different perspective, and I'm happy that Gamini Kerewala has taken an initiative to develop a South Asian perspective of public health and the pandemic. So I have prepared some slides, and it will not be possible to read all the slides because of the time constraint. I will give the gist of these slides and display these slides. So first slide is about the social ecosystem at the eve of COVID-19 pandemic breakdown. What was the social ecosystem in India? And this slide concludes that India was vulnerable to any health emergency, considering political, social, economic situation, and central-state relations. Considering all these things, India was vulnerable to any health emergency. This is the first slide. The second is about the state of public healthcare system at the eve of pandemic. At the eve of pandemic, healthcare system was also somewhat fragile, and healthcare infrastructure was inadequate. This was the Indian situation. So from both the point of view, from the society point of view, so India was somewhat vulnerable, and the system was somewhat inadequate and fragile. Though in India, national health care policy was initiated in 1983, then it was updated in 2002 and 2017. But the main components of the healthcare system had been towards the clinical side, medical side, and the emphasis on the insurance and these kind of things. The social aspect of the public health system was not so much important in the healthcare system in India. Then the first wave of virus to vaccine, preparedness and response. And in this slide, I try to explain the breakdown of pandemic in March 2020, and the central government imposed lockdown immediately, realizing the gravity of the situation. Then, as a result of this lockdown, large-scale migration took place in India. Perhaps it was the second largest migration in India. First was at the time of partition, when subcontinent was partition, and if there was migration, in fact, that was the population transfer. So after that, it was the second from urban areas to rural areas, and it increased the hardships of the people, unorganized sector labor from the urban areas to the rural areas, and adequate arrangements were not made for their transportation or their other facilities. So it has created a sort of chaotic situation while the migrant laborers were going back to their native places, villages. However, the village community provided them some solace and absorbed that labor force. So situation did not deteriorate beyond certain limit, though they faced problem while migrating from the cities to the villages, but within the villages, because of the community life structure in the villages, some solace they got, and they could survive in the villages. So whatever the response to the first wave, it is being considered as inadequate response in dealing with economic and social impacts and consequences. From the government side, though from community side, within the villages, this wave could be managed, and villages were almost unaffected by the first wave of pandemic. There was no much damage in the villages, either in human terms or the migrant laborers, they did not took the virus to the villages. So the first wave, the villages were not affected enough. Then India took initiative for the vaccine development. So the two companies, the Bharat Biotech and the Serum Institute. Bharat Biotech developed the wholly indigenous vaccine, while the Serum Institute had collaboration with the Oxford AstraZeneca. And on the basis of this vaccine development, the government of India has conceptualized the vaccine nationalism and vaccine diplomacy. And ignoring their own people, the Indian government supplied, delivered vaccines to different countries under the global WHO system of the vaccine distribution and direct distribution as on the commercial basis or as the grant of these vaccines. So India could boast about the developing vaccine and delivering the vaccine to different parts of the world. But that pride could not continue for a longer period. India ignored its own population. And when India was boasting, just after some time, the second wave broke out and the Indian life practically paralyzed. Though the vaccination process, Indian government has decided and prioritized the group, the corona warriors, then the vulnerable groups, old age, like that. But it could not stop the spread of second wave. When the second wave broke out, India was not so much prepared. There was no anticipation. There was thinking that India could get good victory of the pandemic. India is better off than most of the developed countries. But when in the second wave political rally, the elections were going on in 5 Indian states. Then one of the Hindu religious congregation, the Kumbh, it takes place once in 12 years. So large number of devotees participated there. Apart from that, in Indian society, marriage is a big social gathering, social ceremony. And because of these kind of activities, these kind of congregations, the virus spread throughout the country, and the villages also came in the grip of this second wave of virus. Moreover, during the second wave of virus, the nature of virus is also different. That is what the WHO has given the name Delta. So Delta virus is more lethal than the first wave of virus. So when the villages came to the grip, the healthcare system was very weak in the villages, so it was very difficult to control the situation. So the second wave proved more lethal and devastating. Heavy loss of human life and economic slowdown, which was already there, it has been intensified. So the second wave has exposed the fragility of the healthcare system in India. I'm not using the collapse of the healthcare system, because in the journalistic writing, we are having terms like policy paralysis and systemic collapse. I have deliberately, being in the scholarly community, used the fragility of the healthcare system, not the collapse of the healthcare system. In the healthcare system, there was a shortage of medical equipments, oxygen, medicines, hospital beds, and the distribution system proved fractured. There was no distribution system, appropriate distribution system to supply equipments, oxygen, medicines, all these things. And moreover, the makeshift hospitals have been created for the COVID patients. International community swiftly responded and extended help. That provided great help to India in the second wave. But the supply system failed to cope with the emerging situation, despite the repeated assurances by the government. Vaccine policy incoherence. Because I have not, as I told, I did not use the term policy paralysis. I used the term policy incoherence. So the incoherence policy in vaccine development, procurement, and distribution. Government did not adopt any coherent policy how to vaccines should be developed, procured, distributed, and it has created a sort of confusion. Different levels, states will procure, purchase from the market, then the private sector will purchase, state will pay higher prices, then the private sector will pay more high prices, and the central government will get the cheaper vaccines, and like that. So it has created a confusion. The second slide is ambiguity in defining role of the central government and state government. The health is in the concurrent list. Both the state government and central government are dealing in the Indian federal structure. So a sort of ambiguity has been displayed. Because during the first wave, central government took all the powers in its hand and central government dealt with the first wave. But during the second wave, central government left all the activities, all the system for the state governments. So it has created more problems than the solution. Meanwhile, the Indian Supreme Court took the cognizance of this incoherent policy. And it compelled the government to take an appropriate decision. Ultimately, Indian Prime Minister announced that from 21st of June, after a few days, the central government will supply procure the vaccines, supply the vaccines, and make all arrangements. So ultimately, the central government came to the task, but it was compelled by the Supreme Court, not on its own. So this ambiguity has been removed, but it's too late now. Then policy incoherence and systemic fragility, controversies and consequences. Several controversies have been raised in media, in scholarly circles, in the scientific community. There are wide discrepancy in cases reported by the government, media, and the international agencies. There is wide discrepancy. The number of the cases. The second point is highly inadequate response to ensure dignified burial and cremation. Dead bodies were flowing in the rivers. Dead bodies were buried and cremated on the riverside. And various surveys and computation models differ on accuracy of the information and data. And there are also discrepancies in the number of deaths reported in hospitals, reported by the government, and the crematorium data. So there is wide discrepancy. There is no accurate information, and which information we should trust and believe, it's a very difficult. And discrepancies of the number of deaths have been reported in hospitals, and then the vaccine hesitancy. Initially, Indians were hesitant to go for vaccination. But during the second wave, the demand for vaccination has started and a sort of rush has been created. So when the rush has been created, it has revealed different kind of divide in Indian society: digital divide, vaccine divide, and spatial divide between urban rural areas, vaccines in urban areas and rural areas, vaccine in digital areas. Large number of urbanites, the urban people, they got registered to get vaccinated in the villages, and the village people, they registered that why the city people are getting registered in villages and they are taking the vaccines which are meant for the villages. And it has generated tensions in different villages, and the police shall have to handle the situation. It became a sort of conflictual situation when the vaccine hesitancy was over. During the vaccine rush, a sort of conflict has been generated in villages. Then another important thing which we can observe in the Indian situation is the virus vaccination and treatment. There are large number of fake information and the predator information about them. In the social media and in the different platforms, a sort of infodemic has been created. Moreover, the treatments were also being prescribed. So some of the gullible people, they are not going to the hospitals for the treatment. They are taking different kind of treatments which are not justified in the medical science terms. So a sort of infodemic has been created along with the pandemic. The opening of, then this policy incoherence and the systemic fragility is opening up new vistas of research, innovation, and knowledge creation in different disciplines, including social science. And it has renewed a new debate, efficacy of indigenous Ayurvedic versus allopathic treatment. And this is well known about Baba Ramdev and Indian Medical Association. This debate is going on because the IMA is saying that Baba Ramdev is hurting the dignity of the medical science, whereas Baba is saying that Ayurveda is more important, yoga is more important, and there is no treatment of the pandemic, and why they are giving treatment. So the new a debate has been renewed in Indian society about Ayurvedic medicine and the allopathic medicine. I don't know how it will be concluded, but one thing is certain. The allopathic hospitals, particularly in the private sector, they are exploiting the people like anything, and there will be certain restriction on the allopathic private sector hospitals, and there will be some kind of strict regulation out of this the renewed debate of allopathy versus Ayurveda. Then what the Indian aspiration and assertion during the pandemic? Vaccine nationalism and vaccine diplomacy for rejuvenation of Indian foreign policy. So India has attempted to rejuvenate its foreign policy through vaccine nationalism and vaccine diplomacy, taking pride of developing 2 vaccines and supplying to the different parts of the world and the developing countries. Then second, a demand for patent waiver for unhindered faster vaccine production. International level, India has put a demand for patent waiver. Africa and even United States supported, but European countries like Germany, they are not supporting for patent waiver for production of the vaccines. Global solidarity and vaccine equality for leveling of vaccine divide. India is demanding for leveling of the vaccine divide and strengthening multilateral agency like WHO. So this is Indian aspiration and Indian assertion that multilateral agencies must be strengthened and vaccine divide must be leveled off, and there will be large scale mass production of vaccines. Major takeaways is the last slide. I think I'm not taking more time. What are the major takeaways from the pandemic in South Asia? The healthcare system must be revamped with policy coherence and robust strategy to ensure effective health service delivery in every country. This is the first takeaway from the pandemic situation. The second one is healthcare spending must be increased up to 3% of GDP. In India, it is 1.23% of the GDP, which is very less. In most of the developed countries, it is very high. It is up to 2 or 3%. And countries like Korea, they are spending nearly 4% of their GDP. So it should be reached at least 2 to 3%. In South Asian countries, it's very less. The greater need of revisiting federalisms in case of India particularly, and prioritizing different sectors of the economy. These 2 things, the center-state relations have become tense during the pandemic. So there must be revisiting of federalism, a federal structure in Indian society. Secondly, the various sectors of the economy must be reprioritized, because in India, the services sector and the manufacturing sector is getting priority instead of agriculture. So there must be reprioritization of the different sectors of economy, because agriculture had established its credibility during the pandemic crisis by harboring large number of poor people, those who had become destitute within fraction of a second when lockdown was imposed. So the agriculture provided solace and relief to them. So there must be reprioritization of the sectors of the economy. Then the South Asian region is India-centric, and thus development in India impacting other South Asian countries, it is more tangible during the pandemic. Though everyone understands India has some impact, but during the pandemic, the impact has become more visible when India supplied the vaccines to all the neighboring countries. Then India should shoulder greater responsibility in development, security, and progress of the South Asian countries, and it has been exhibited by the vaccine Maitri. Maitri means friendship. It's a Hindi term, vaccine Maitri. So India must own the greater responsibility for the development of all the South Asian countries. India must extend unconditional help to all these countries, and it has been exhibited by the vaccine Maitri. SARC must be strengthened with institutional mechanism to for crisis and regional health care, for which India should take initiative.
With that positive note, can we conclude the presentation?
Yeah, only 2 points, sir.
Yeah.
Then the national and regional level efforts must be initiated for preventing anticipated third wave of pandemic. And in a sense, I must say, keeping in view COVID-19 inappropriate behavior of the people, policy incoherence, systemic fragility, inevitable third wave being predicted, the greater disaster is in offing if appropriate preventive and proactive measures are not undertaken right at the moment. That's all. Thank you very much.
Thank you, Professor Karori Singh. Your conclusions are very important, and definitely we will take them at the discussion time. Now we will turn towards Dr. Nishal Pandey. He's a very long-standing friend of RCSS. Dr. Nishal Pandey, floor is yours.
Thank you, Professor Gamini and the Regional Center for Strategic Studies for this kind invitation. I see a lot of friends, Professor Munis Ahmed, Saloni Singh, a lot of other friends. I hope you are safe in this pandemic situation. Well, I think it would be not proper for me to say that both the presentations would be exact ditto to the situation in Nepal, because we can just say that the situation, the health, the problems, the issues grappling the state, the condition of the hospitals, lack of ICU beds. You know, we had last 2 weeks was just terrible. There was no oxygen cylinder. The situation is pretty much the same. This unprecedented health crisis has exposed the lack of planning, the lack of emergency medicine, shortage of doctors, and the entire condition of health services in Nepal as well. The situation is slightly different from other societies, especially the Indian context, is that we also had a devastating earthquake in 2015, which saw the untimely death of 8,000 people. And before that, we had the 10 years of Maoist insurgency, which saw 18,000 plus deaths. So and today, as I speak, there is a devastating floods and landslide that is going on. So there is a lot of crisis brewing in the country, and coupled with that, unfortunately, these are all nature-driven crises, but the man-made crisis is that we also have a political crisis. Our parliament has been dissolved twice in a matter of 3 months. The House was reinstated by Parliament, by the Supreme Court, and then the Prime Minister could not get the vote of confidence as he desired, and he dissolved the House again. So we also have a political crisis. Now, how are we going to conduct elections within 6 months? Because conducting elections is not just got to do with voters going to the ballot box and casting their votes. It's also got to do with these mass rallies, these election rallies, door-to-door campaigns, etc. So will that be a super spreader event in itself? As we saw in the West Bengal elections, that the fact that there were so many rallies taking place was also a contributor, and the Kumbh Mela, the contributor to the spreading of the virus in India. And we don't want to repeat the same mistake here in Nepal. Another issue that I wanted to highlight is the crisis of vaccines. India was kind enough to give us the Covaxin, and the first dose was given to the elderly population, but then the second dose is not available. The government of Nepal has already paid to the Serum Institute in Pune, but the institute has clarified that there is now a court case in the Supreme Court of India, and it cannot supply vaccines to foreign countries. Our standpoint has been that we don't deal with the Supreme Court of India; we deal bilaterally with the government of India. And but the second dose has not been given. We have already paid the installment, so that is a crisis in its own. Because if the second dose is considerably delayed, Then there are scientists who say that the first dose will be useless. It has already been about 2.5 months that the first dose was administered. From the Chinese side, we got the vaccine, the Verosil, and in my age group, we were allowed to get this is my vaccine card. So this is now the new passport for international travel. And I got both the doses of this Verosil given to us by China. Now, again, the Russians wanted to give us Sputnik vaccine. The government of Nepal was not very eager 4 or 5 months ago to purchase or to get it. And now, since the vaccine is in shortage, now we want to buy the Sputnik also. So it's a crisis of its own. The Covaxin is not available. The Chinese Verosil, now we got the first dose in a grant. Now we want to buy the Verosil. So this has now become more or less an arms trade. There is so much of money involved, and we don't know what to do with it because the people are angry. They want the second dose immediately. Bhutan has already vaccinated 93% of its population. So the Nepalese are wanting an answer from the government. Why hasn't the second dose been available? And now the president of Nepal is sending out letters, virtually SOS letters, to the president of the United States, the Queen of England, the president of India, the president of Russian Federation. And the letter obviously we don't know where it has reached, probably the desk officer in the foreign ministries. Then the question about the open border. We have an open border with India. As India faced an unprecedented crisis of this second wave a month ago, we should have been steadfast to close down the border. Every sovereign nation has a right to close its border when there is a major crisis. We do close our border during times of elections in India and during elections in Nepal. But at this time, the government was very late in its response. And as Nepalese migrant workers started coming home, our second wave started. Last year, it was much better in our handling of the pandemic. But this year, it has been a complete collapse of the health system. The lack of oxygen cylinders was simply terrible in hospitals. I mean, people were dying. People were not even getting beds in the hospital. They were outside in the parking lot with oxygen cylinders inside their vehicles. That was the condition 3 weeks ago. Our situation is a little better now. The problem, which nobody envisaged before, was that oxygen was available, but we had a lack of cylinders. Now, nobody even thought about this. Perhaps we used to import cylinders from India, and as India itself was not in a position to sell these cylinders now, then we were hit by this major crisis. Somehow it just did not come to our mind that cylinders was not there. We were producing enough oxygen, but the cylinders are not just available. Now, this is what crisis management is all about. This is what disaster management is all about. And we should have learned this from the earthquake of 2015. As the earthquake struck Nepal in April 2015, all the people were on the streets and they were wanting tents from the government. And there were no tents available. A classic case. Then we started importing tents from China. So this should have been envisaged that in a health emergency, we will be needing oximeters, we'll be needing extra ICU beds, we'll be needing oxygen cylinders. Somehow it just did not come to our mind. So therefore, the entire response has been, and I don't want to blame the present government for it, it just inherited this crippled system. Thirdly, a new crisis is now brewing because we are now started to relax the lockdown a bit. And as we relax, of course, the restaurants will open, the hotels will open. This is a wedding season. People who don't want to stop their marriages, etc., etc. And now it will go for another wave. But how do you resurrect this economy? I think this also needs to be highlighted. We cannot just go on and on with a lockdown. How are we going to resurrect this economy? Nepal is based economy is based on remittances and tourism. The migrant labor has not been able to fly because there are no flights available. Malaysia has been closed for months in a row. Nepalese migrant workers also go in large numbers to South Korea and Japan. That has been closed. They have already passed their language examinations to go to Korea, but it has not started yet. Gulf is closed because there are no flights. Jobs are available in Qatar, especially because they are doing the World Cup and they are frantically wanting to finish these stadiums, huge stadiums that are coming up in Qatar. So they need Nepalese workers, but there are no flights available. So how do you resurrect this economy? And we are, 28% of our GDP is based on remittances. If something happens to that, we are on a financial collapse. Tourism, it has it has come to a zero. Hotels are closed. Professor Muniz, you'll remember the Hotel Annapurna, where perhaps you have stayed several times. That hotel is a 5-star hotel in Darbar Marg, and it stands closed because all the rooms are completely empty. And the problem with labor, relationship, trade unions, and so forth is that they'll still want their salary even if the hotel is closed. So the best thing that the owner can do is close down the hotel and say to the government that I have closed down business. And then he does not need to pay the salaries and perks for the workers. So that's what these owners have opted for. So a lot of hotels are closed. Tamil gives you a deserted look. How can we sustain this? So government has to have an economic recovery plan. Now, Bangladesh has already gone for a V-shaped recovery, I believe. My Bangladeshi friends have said they are expecting a GDP growth of 6.8. We were on a minus till a few months. We are now aiming for a 2.1. Now that is hardly enough. So therefore, on the issue of vaccine diplomacy, the embassies, perhaps all our South Asian embassies can work in tandem in European countries and in America and in London, rather than the Nepalese embassy and the Sri Lankan embassy, the Maldives embassy, trying to get hold of the joint secretary or the undersecretary. Perhaps we can have our own South Asian lobby in these capitals, in Brussels and in other capitals, so that we can get hold of those vaccines. Now, United States has announced that they will be providing vaccines to Nepal, but when is it going to come? This is the real question. Also, perhaps we have to rethink about our regional organizations. Now, where is BIMSTEC in all this crisis? SAARC has had several rounds of virtual meetings, Zoom meetings. The health ministers met. But the money the funds that was allocated, governments are more eager to spend it bilaterally and not give it to SAARC. You see the problem? A lot of funds have been allocated, but they want it to be spent bilaterally, not at the regional level, not giving it to the organization and the organization supporting us, but they want to do it bilaterally. But the name will be used as SAARC fund. So this is incomprehensible to me. And then what is the use of SAARC? BIMSTEC, I don't see any presence at all. I don't see any role of that organization in the course of the pandemic. BBIN, I have not heard anything as regards to the pandemic. So the same case of 2015 earthquake, I see exactly the same case as far as Nepal is concerned. When the earthquake, the deadly 7.9 Richter scale struck, our Prime Minister was outside the country. He was flying from Indonesia to Bangkok, and he heard for the first time about the earthquake from Prime Minister Modi, who called him. And the Indian Army was the first responder to the crisis. They landed within few hours at the airport. The PLA, the Chinese, they were the second responders. They came in with shovels and concrete cutters and sniffer dogs and health equipment to save whatever they could save out of this rubble. The American Specific Command got into action and they were the responders. So here we are on pretty much the same situation. We don't have anybody else. The Indians and the Chinese and the Americans, and a little bit coming from the European Union, as far as health emergency equipment are concerned. So have we learned from these disasters? Nepal as a nation and South Asia as a region. we haven't learned anything at all. We grapple with one crisis after another, and the same response mechanism, very slow response. Today, as I speak, we have a major flooding going on, major landslides. People are killed already in the western area of Nepal, and so therefore the situation remains the same. Final point that I wanted to mention was the health crisis that is going to come post-COVID. I mean, scientists are already speaking about a mental health crisis. People are stuck at homes. Children are not going to school. Boys are playing video games the whole day long. Girls are in TikTok. The young girls are in TikTok. I mean, how long are you going to go with this? There is going to be an educational crisis. Schools and colleges are running these virtual Zoom classes. But then there is a question of, the data charges, internet connectivity. And the teachers themselves do not know how to run these online classes. Students are much smarter. Teachers are from a completely different generation. They want to ask questions. The teachers are not responding. So many problems, I mean, in the urban centers, the children are better equipped because they have internet connectivity, a better connectivity. What do you do in rural areas? They are in a mobile phone. They are in a phone taking these classes, and there are data charges. Who is going to pay for these data charges? Schools are asking for fees, whereas they have not even run classes for months in a row. So we see another kind of a crisis coming after the pandemic. I think we as a region have to strategize, think ahead of not only the health crisis, but also economic recovery, unemployment, education, the mental health crisis in the post-COVID world. I'd like to again reiterate my sincere thanks to Professor Gamini Kiravella, RCSS, for thinking of this noble initiative of bringing us together. I'm sure something is going to come out in a written form after this Zoom, so that it will be useful to WHO, to the UN agencies, as well as our think tanks. Thank you very much.
Thank you, Dr. Nishal Pandey. Yes, I fully agree with you. We South Asians have very common things. One is we don't learn lessons from our past. That is common to Nepalese, Indian, as well as Sri Lankans. With that, I would like to invite Professor Munish Amar for his presentation. After that, we will have open discussion. Professor Munish, we are eager to hear from you.
Thank you very much, Professor Gamini. And I also wish to thank RCSS for this timely initiative, brainstorming session on the public healthcare system and COVID-19. I don't have a PowerPoint presentation as such, but I have points. And some of the points which I would like to emphasize on. The first is about in case of Pakistan, for pandemic, have been at the governmental level to deal with this crisis, pandemic crisis. Third, the implications of pandemic crisis. As far as the background thing is concerned, on February 26th, 2020, I remember very well, the first case was detected of coronavirus. And the case, the student from my department, International Relations Department, University of Karachi, he had gone to Iran for this pilgrimage. And when he returned, he brought that virus, which was detected on February 26, 2020. So that was the first case in Pakistan. Then there was another case in Islamabad. Then, the first wave, it continued from March to June 2020. We were not ready to grapple with that type of a crisis. The government responded by not going for a total lockdown. No. And that is what was the Prime Minister's argument, that if we enforce total lockdown, then it will primarily cause a lot of damage as far as the working class concerned, the laborers, the daily wagers, and so he ruled out. But there was a lockdown, absolutely, in April and May. But the lockdown, whereby the restaurants were closed, educational institutions were closed, then shopping malls were closed, businesses were closed, but the industries remained open, factories remained open. And it was the Supreme Court which in May, early May or second week of May, gave the verdict that the government must open up. So the lockdown ended up with a partial lockdown. That was the first wave, April and May 2020, April, May, June. Then there was the second wave, November 2020 till January 2021. The first wave was not that lethal, but it had psychological implications as far as the health system concerned, that we were totally vulnerable. How to cope with this, we had no idea. To deal with this pandemic. That I will discuss briefly later on, that how psychologically people were. Societal crisis, economic crisis. So the second wave, November 2020 till January 2021, was not that dangerous. The lockdown which was experienced during the first wave, that was rather eased during the second wave. But the third wave of coronavirus, COVID-19, April 2021, that was terrible. I mean, like around 50% of the deaths caused as a result of pandemic that happened during the third wave, April 2021. Now, the situation on the ground is, the health situation on the ground is that the government has claimed that it has managed the crisis, which is true. Absolutely. So far, the total number of COVID-19, 21,943,027. Recovered, 880,000 people recovered. Active cases as of today, 44,236, out of which 3,192 patients are admitted in hospitals. Pakistan is 26th highest death toll in Pakistan, 26th highest, and 27th highest number of cases. So we have managed that crisis, and we managed that crisis because of institutional measures, which is the second point. The government established a National Command and Control System, NCOC, headed by a federal minister, a team, and the NCOC, National Command and Control, National Command and Control Center, that was basically to coordinate with the provinces of Pakistan, to provide doses of vaccines, to deal with other measures. And then the second institutional measure, that was Federal Ministry of National Health Services. Federal Ministry of National Health Services. Now, these two institutions together, they have managed to arrange 11 million doses of vaccine for the month of June. Around 4 million people have been vaccinated. NCOC is claiming that daily 300,000 to 400,000 doses will be administered. And then if we take into account this figure of 300 to 400,000 doses administered daily in Pakistan, That means that Pakistan is certainly better than countries like Australia, Switzerland, Portugal, and Belgium. We got, of course, huge quantity, not very huge, but some quantity of vaccines from China. Then, of course, the AstraZeneca vaccine, the National Command and Control Center has allocated $1 billion on June 9th, on $1 billion for the procurement of vaccines. And then on June 10th, the NCOC stated that vaccinations shall be must for all public and private sector staff. All the government servants, semi-government servants, those who are working in various private offices, mandatory. And my province, that is the province of Sindh, is far ahead than that. The chief minister arguing, saying that if the government servants, including those who are in, the semi-government servants, they fail to get vaccines, both the doses, then they will not be given the salary, they will not be paid the salary of July. That is acting as a deterrent. There's a crisis, I mean, of course, but the mandatory type of measures which the government has announced, that you will not get any, you cannot buy a ticket, meaning to fly or train ticket. You will not get a room in a hotel unless you produce a certificate that you have been vaccinated. How the government has dealt with it? It established the expo also, there's an expo center. So the government made sure that people should be provided vaccines and free of cost. And such vaccines should be at their doorsteps. So in my own university, that is University of Karachi also, there's a setup whereby the Sindh government, those who want to get the vaccines, they can go there. But then there is another dimension to that. There are a large number of people who have refused to get themselves vaccinated. And they have been basically under the impression or the conspiracy theories. I mean, like so many type of false fake news that those who have been vaccinated, they will die in 2 years' time, or they will develop diseases. I mean, absolutely wrong. So the government is trying, has launched a media campaign, a PR campaign to dispel all such notions which basically are against the vaccines, the doses and all that. Now, we basically experienced a lot of crisis we were not used to, certainly. But the government, the federal government particularly, argued, came up with the idea of smart lockdown. Very interesting. A smart lockdown, places where you have the hotspots, like in the New York City, the governor of New York City, Andrew Cuomo, last year, every day he used to, give a news conference and mention about the steps taken to deal with the pandemic. So the hotspots, identify the hotspots, impose a partial lockdown, and then contain that virus, containment of that virus. One thing which has helped us, basically, I don't know, but the third wave has been lethal. It has, these days, the total, you can say, infection rate in Pakistan yesterday was only 1.5% infection rate in Pakistan. Karachi city is the highest, that is 9%, 8.5 to 9%. But overall, the testing done, the infection rate has dropped to 1.5%, which in the month of April and May was around 12%. How that has happened? It has happened. It has happened also because of the fact that the phenomena which we are basically told about immunity system, that the people of Pakistan, they are a bit lucky because of the immunity or the herd immunity, that they have not been vulnerable as far as coronavirus is concerned. But that is wrong. That is not entirely true. There are people, I mean, large numbers in Pakistan, and this pandemic has targeted everyone, regardless of their social background, economic background, things like that. Now, the restrictions were imposed. The Sindh government was accused of being very brutal. That is 2 days total close, 2-day closure. Markets will open at 6 and close at 6. That's it. The public transport was almost, suspended. The inter-provincial transport suspended. So the Sindh government was the first, it took the first deterrent measures to deal with the spread of this virus. Now, the implications of this pandemic. Certainly, in the beginning, of course, there was a bit, chaos. How it has, which Nishal was also mentioning, that the educational institutions closed, the universities closed, the schools closed, online system, online teaching. Now, a lot of psychological and sociological upsets have taken place. The implications at the educational level, that when these are closed, now they have reopened, almost reopened, and then, they were closed last year, March, April, and May, reopened in August, again closed in November, reopened, and then closed in April. So that was basically something which disturbed our way of life. It has disturbed our way of life. And how can you have the SOPs, standard operating procedures, social distancing, that in a situation when you have like the city of Karachi, which has 22 million people, and Pakistan is a country of 222 million people. So even then, the implications are such that the government last year, it announced a stimulus program of several billion rupees, which was called as the SAS program, whereby 14.8 million families or 100 million citizens were provided economic relief. Just once last year. This year, in the third wave, the pandemic, the lockdown, there has not been any relief. So therefore, the restaurant owners, the travel agencies, the hotels, the education institutions, the transporters, they threatened the government that if you fail to open up, we will open things on our own. So that was a big crisis 2 weeks ago, and the government agreed to. It came under the pressure. The condition that you will maintain the SOPs. But the SOPs are basically, on paper. Absolutely. How many people are wearing masks? How many people are maintaining social distances? Not many. So it is not in our culture also. Since it is not in our culture, it is not, implemented. So I would like to end here by saying that Pakistan has been a bit lucky, although with 21,782 deaths. The thing is basically that all the 3 waves, the first wave, the second wave, the third wave, have been managed, and it has to do with the National Command and Control Center, the Federal Ministry of National Health Services. But there are issues. Today in newspaper, in major newspaper Pakistan, there's a news that there's a shortage of vaccines in major cities of Pakistan. The government claimed that it has plenty of stock, abundant stock, but then it has been noticed that the vaccines are not, and people who go there for the vaccines, like the Expo Center in Karachi or in Lahore or elsewhere, they are told to come tomorrow or day after tomorrow. So that is so $1 billion which have been earmarked for the purchase of vaccines. That is, and the government has been criticized that it has not handled it properly. But the fact is basically that there was no other option. So we have managed, but it doesn't mean that our healthcare system, and I totally agree with other speakers, that there has to be a focus, there has to be a priority, there has to be an emphasis as far as spending on health is concerned. I don't think that billions of dollars of weapons of mass destruction or nuclear weapons, they have totally failed. I mean, billions have been spent as far as the armaments and military expenditure all over the world in South Asia, but they have not been able to deal with this virus. So a time has come that we should focus on as far as educating people about basic health requirements, investment as far as health is concerned. And we came, at the risk, and I will just end in a minute's time, a heavy risk a month ago, when it was reported that there were not many oxygen beds, available. The ventilators were, very much in short supply. And one solution was basically that the Karachi steel mill, which is closed. So in that steel mill in Karachi, there is a huge oxygen plant, which is not working, which is not functional. So you basically restart the oxygen plant so that at least the supply of oxygen can be. So I'll end here, and then I'm looking forward for meaningful interaction. Thank you very much.
Thank you, Professor Moniz. Now we have 4 presentations. These presentations would provide very good basis and foundation for panel discussion. One thing that we can gather from all presentation is how common the problems we are facing as far as COVID-19 pandemic is concerned. At first, all the countries, we were very complacent that we are doing well. Then later stage, we see the problems came up, and we are facing real structural crisis in governance. The pandemic highlighted the totalistic crisis of the systemic crisis that is we are facing in South Asia. With that note, I would like to initiate the panel discussion. We have very strong panelists from Peradeniya University Community Health Department. We have Professor Ananda Jayasinghe, Professor Dhammika, Professor Sanath Abhiratna. We have the Dr. Harish Chandra Lakkumar, Professor Dr. Samarkand, Dr. Richard, and Professor Madhubala from Delhi University, Professor Indralal, Ambassador Shahid Ahmed, Ashmat, and Professor Tudor Shilla, Professor Saloni Singh, General Vijita Tennakong. With all, I think we expect very good discussion. To begin with, I would like to invite to begin the Dr. Harish Chandra, who is the psychologist, and the Professor Harish Chandra can bring psychological dimension of this crisis. Professor Harish Chandra, can you please contribute?
Yes, thank you, Professor Kiravella. I must thank you for inviting me. And initially, I must thank all the speakers and other panelists. In fact, the acute management is done with success and with failures. But the other aspect of this is psychological aspect. It is very common. In the acute stage, there is severe fear, the anxiety and depression associated with this illness. And this has been increased by the, of course, media, the way that media is handling the issue. In fact, a lot of information with competition with the media institutions, and the way that they assaulting people with informations and produce fear, anxiety, and depression. And in addition, that in the empirical data is available in Sri Lanka that is done with pregnant mothers, increased anxiety and depression with significant increased levels of anxiety and depression in pregnant mothers. And in clinical practice, we meet people who developed anxiety, and those who had these illnesses, depression, increased their severity or relapse in the illnesses. That is the acute stage. And there are enough evidence to say there would be long-term effects on the illness on the brain. It will produce something like chronic fatigue syndrome, something like that. But we are not sure what the long-term outcome would be. In fact, in Sri Lanka, there are some measures taken by Sri Lankan College of Psychiatrists to handle the acute situation. That is also, I don't say it is adequate, but some measures in quarantine centers and also in the clinics, psychiatric clinics. But I presume that there was some measure to detect the long-term effect of the long-term psychological sequelae of these patients from now onward. I wonder whether it is done in India, Pakistan, and Nepal, what measures that they have taken and what extent they are facing these psychiatric issues, post-COVID psychiatric sequelae. And even though the acute stage is managed, there are a lot of things left, not only with the patients who are having it, what about the patients, people who lost their close ones, the grief, the bereavement, and the long-term effect of losing their breadwinners and close relatives and loved ones. Therefore, it is evident that there are we are going to left with a lot of psychiatric problems throughout the countries, and especially with regard to anxiety and long-term depression. I would like to know from other speakers what measures that they have taken in their countries. Thank you.
Thank you. Now the open for anybody to make the comment or raise a question or query.
Okay, Professor Gamini Kiravella, I am Dilesha from University of Ruhuna. Because can you give me 2 or 3 minutes to make
yes, please go ahead.
Because we are talking about COVID-19 pandemic and public health strategies that we can implement in order to control the pandemic. That is I think the main issue. In that case, I think these 4 speakers were talking about various things that are very important for us to understand. But I would like to emphasize few things. First one is all of them were mentioned about cooperation, intersectorial collaboration and cooperation. That is lacking. I mean, there are different departments, ministries, and type of people in different sectors who are not collaborating well in order to solve this problem. There are people from political movements, there are people from army and police, there are people from various other health services. They are not collaborating well. That is one of the major issues that they were talking about. The second one is we all are from Southeast Asia, middle or low income countries. Therefore, there is a huge financial problems here. So in that case, we need to address that thing properly. Whatever the sort of equipments or finances we do have, or resources that we do have in prevention. Now, when we are talking about prevention of COVID-19, right, vaccines is one preventive measures. The other things like behavioral issues, like say, for example, seeing all these things. I mean, these type of things from public health perspectives, have we addressed properly, or are we achieving our objectives in this prevention? Of course, now not only prevention, but curative medicines are also in progress. There are some clinical trials going on to, say, for example, reduce their viral loads. So if they are successful, then we can save millions of people. But in public health perspective, and this is connected to this intersectorial connection. In that case, we do have nurses, but do we have nurses capable of handling COVID patient? That sort of question. We need, like, say, for example, personal protection level in public health. Have we addressed these issues? And whether we have a good reporting system, whether we are collecting data accurately, and are we reporting it? And screening and monitoring of people in different districts. Do we have a proper system in order to support the public health system and to support the leaders in order to take their decisions? When we are talking about these things, the final thing about psychological sort of, there are psychological problems. I understand that the general population, what sort of have in relation to COVID-19, in relation to their day-to-day life. So these, we have not addressed these things, even in the psychiatric or medical system. We have only targeted that people who are suffering from these.
Yes. Can you
suffering from psychiatric diseases, support from the health system in order to do this. Thank you.
Yes. Can you, when one person speaks, can you others please mute your your position? Then we can minimize the disturbances. Now, okay, it is open for open discussion. You can raise question either directly to speakers. Yes.
Can I say something?
Yes, Professor Indralal.
Can I talk?
Yes, Professor Indralal. Yes.
Myself, Shashi Upadhyay.
Can I speak? Yeah.
Yes.
Yeah. Yeah. Thank you very much, Professor Kiriwala. I have a few points for and also thank you very much for all the presenters. It's a very good presentation. And but I have one or two comments. Well, if you take the Southeast Asia or Southeast Asian countries like Vietnam, Singapore, Cambodia, and most of the countries, they have managed the COVID situation very well. But if you come to the South Asia, we were not that good in managing the COVID-19 situation. Now, therefore, my question is about the treatment part. To what extent China, Vietnam, and Cambodia kind of countries has used indigenous medicine to take COVID-19 situation. I heard that, I don't know whether it is really true. Even in China, there are 3 levels of hospital: allopathic plus Chinese, and then totally Chinese. And also then Vietnam also have used, and also I think that even in India, there is a trial that allopathic system is combined with the indigenous medicine. Therefore, what I'm asking is that this health system, particularly, there is no complementing each other kind of approach is very, very less. And probably the allopathic groups are not welcome any other groups for this particular business. Therefore, they want to manage this particular pandemic by themselves. I think they may have to think about getting additional support from other health systems also. And then, but even though it is the case, but large number of people in South Asia, they regularly take lot of home medicine, indigenous medicine for protection purpose. But in the final one is about the vaccine. Even the vaccine is going to be a serious case for the South Asia, including Sri Lanka, because I think most of the people mentioned about the economic vulnerability. Now, hardly anyone mentioned about even after taking the second dose, as of the now result says, after 8 months of taking second dose, we may have to go for the third dose. Therefore, we may have to spend large sum of money for this COVID management exercise. And if I mention even Vietnam, the COVID-19 deaths per 1 million population is even less than 1. In South Asia, Sri Lanka is of course best for 1 million population, only about 65 deaths per 1 million population. But now India, Sri Lanka, I think Nepal also same case. We are observing very large proportion of COVID deaths at home. That means some sort of failure in our health system very significantly. Therefore, in that situation, complementing the what you call Western medicine or the allopathic system with the indigenous system to some extent need to be incorporated. That is my basic argument and basic. I would like to get some comment from our Indian and our Nepali, Pakistan groups. Thank you.
Yeah, at the end of the, towards the end of the discussion, we will get the opportunity to respond to all the questions. Now, I would like to invite Dr. Ishtiaq Mekri.
Thank you. Thank you so much. It was a great discussion, and I'd like to felicitate RCSS for organizing such a great debate on such an important issue. And there were some excellent presentations, I shall say, from India, especially Dr. Singh and Dr. Pandey. And there were certain very great terms used, such as policy incoherence, policy paralysis, as well as vaccine nationalism. I really love that term, vaccine nationalism, used by one of our panelists. And Dr. Monis Ahmed was very categorical when he defined how Pakistan has coped with this situation. And he very candidly talked about the myths as well. So what I really want to say is that as far as Pakistan is concerned, in the next 11 months, Pakistan wants to vaccinate around 100 million people, which is almost half of its population. And for that, it has allocated around 21 billion rupees as well in the federal budget. But one thing here I would like to make a point, because we are discussing public health and we are really concerned with South Asia, as one of our panelists very rightly said, that we live in a very poor region, in a very underdeveloped region. So the culture and the tradition is that as far as every family is concerned, irrespective of religion, caste and creed, is that whenever we are in a problem, we share our problems. Whenever we are in a mess, we land in some sort of a nightmare. It is only the friends, the neighbors, and the colleagues and the acquaintances who come to your rescue. Do we really have such a strategy here? Because we faced one of the greatest pandemic of our times, as rightly pointed out again by Dr. Monis Ahmed, where nuclear weapons, lot of investment in arsenal really failed to deter that invisible enemy among us. So South Asia, unfortunately, lacked a coherent strategy to deal with huge countries such as Pakistan and India. The cooperation was lacking. There were rebuttals. Friendly gestures were turned down. It took so much of time. For almost a year, we were waiting for the vaccine. We were looking up to the West, that the West or China will do something. There was no coordination. And as rightly pointed out again by one of our panelists here, just now, the gentleman who spoke, he said that there are certain other medical therapies as well available, such as Ayurvedic, such as homeopathic and other things. We never even touched on those. We never even had any sort of collaboration to invoke, maybe there is a science, maybe there is a theory, maybe there is a therapy that the South Asian region could have collectively enriched on it, could have banked on it. So this is what is lacking, and I would not like to say anything on the SARC because it's a defunct organization. It has hardly done anything. But here I think that the communities should have risen above their petty interests, and there was a real lacking, substantial lacking as far as fighting this pandemic is concerned. We were really cornered by our own respective governments, and whatever the governments did, we were just under their tutelage, shall I say. So there is a lack of coherence, and this is where I think a new thinking should be born at this point of time today, that is on 16th of June, that the collective countries, that the collective communities, especially the intelligentsia, the people who are on this panel, could lead the front by just invoking a strategy whereby the community should come forward, and there should be more and more investment in the health sector and more collaboration, irrespective of what the political governments and their bureaucracies have to say. There has to be a trans-boundary cooperation. This is how we can fight this pandemic, and maybe we can lead from the front. South Asia should show by its example. Thank you very much, sir.
Yes, thank you. One of the issues that came up in the discussion is the politics of pandemic and the politics of the pandemic mitigation of the measures. I came to know that there is an informal the group of the doctors who are working on that on these political aspects and the vaccine diplomacy. Dr. Richard, are you there? Dr. Richard? Okay, he's not there. Okay, now open for discussion. Yes.
I'm Dr. Samarakon from the Institute of Indigenous Medicine of the University of Colombo.
Yeah.
So I must thank first RCSS to give opportunity to participate in that valuable webinar, and thank for all keynote speakers. We learned a lot. Especially, I must thank Professor Chandralal because I wanted to raise that issue here. So Professor Karori Singh from India also raised the same issue, that there is a debate between Ayurveda and the allopathic medical fraternity regarding the COVID-19 control. So according to the WHO, as you know, there is no known treatment for the COVID-19 treatment. That this much of patient is cured and left the hospital. My argument is, if there is no treatment, how they did cure? And I think this is totally depend upon the individual's immunity and the prevention. If we have to take as every possible steps to prevent the disease. Once we get the disease, the final result will depend upon the immunity. So in this case, actually, as the member of Ayurvedic fraternity, we have a lot of things to do. We have not only the Ayurvedic fraternity, but also from the indigenous medical fraternity in Sri Lanka has a lot of preventive measures. So my argument is why the allopathic field is not allowing to indigenous doctors to take part in this COVID-19 treatment movement, because health has no allopathic health, indigenous health, Ayurvedic health. Health is health. So we have very good manpower, very good resources in Sri Lanka to participate in this COVID-19 treatment movement. That is our grievance actually. So if we get a chance, so we are very willing to take part in this movement. Recently, we heard that 50 hospital, Ayurvedic hospital is going to develop as COVID-19 treatment centers, but they are actually taken only for the hospitals, but there is no chance to participate for the Ayurvedic doctors. So that actually this is very unfair situation. Right. Thank you.
Hi, may I say something, please? Professor Kirawala? Can you hear me?
Yes, I can hear you. Floor is yours.
Okay.
Professor
I
Bala?
just want, yes, I just want to say one thing about, this conflict between Ayurvedic medicine or indigenous medicine and allopathic medicine. I think one of the problems that we have in India today with the proposals that were put forward by the Baba Ramdev were that they were not based in science of any kind, right? Now, I think if indigenous medicine were to explain to us the science on which they are based, there would be many more people rooting for indigenous medicine. After all, it is cheaper, it is community-based, it can go much further in poorer populations than allopathic medicine can. But the problem really remains that if we are to base our healthcare frameworks on medicine, on science, and the scientificity of our medical processes, then I think indigenous medicine practitioners must step up to be able to explain to us the kind of tests they have done, the kind of science that they have based their medicine on. And that would be a great advantage, I think, truly, for our people. Many of us believe in indigenous medicines and indigenous solutions to small problems that we have. But in the current pandemic, can we safely say, when lives are at stake every moment, that we will now shift to indigenous medicine? I think that's a non-starter as far as many of us are concerned. I mean, that's, really just to say what a lot, okay, just to sort of put up front the problem we have with indigenous medicines right now and the indigenous framework for medical health and for public health right now. But I wanted to say another thing as well. We have, our governments have, in India at least, our government has failed us. Many of us are very, very clear on that. The newspapers will tell us that. The evidence on the ground tells us that. The number of dead bodies that we cremate or we bury or we throw into our rivers tell us that. But civil society actually stepped in. So I'm wondering what the experience was in other South Asian countries, in Sri Lanka, in Pakistan, in Bangladesh, or in Nepal. And I asked this question because civil society in India in the last 4 or 5 years has been discredited consistently by the government and has been suppressed at almost every level. And yet, when the government failed, it was people who actually stepped in. It was civil society that stepped in, organizations, institutions that were not related to the government, and ordinary people at the level of communities put themselves out in terms of money and place, and whatever, to help their neighbors or to help other people they did not know. So I'm sort of wondering whether really when governments fail us, can civil societies get together, right, across South Asia and share their experiences in terms of what they learned and what they did? Thank you.
Yes, very, very important point, Professor Madhubala. That is the case in Sri Lanka. Role of civil society in mitigating the pandemic and handling pandemic situation is very high. The civil society is something more than NGO community. When government, in Sri Lankan government as well as other South Asian government discredit civil society, highlighting certain weaknesses of NGO community. We have to take, at the same time, we have to use that opportunity to rethink about the civil society and their work style also. That is also the COVID-19 pandemic posed a challenge not only to the government but also civil society. With that note, I would like to, there are few questions the place on the chat box. I would like to ask Ms. Nimni Jayatilaka, are you here? Can you
Yes,
please
Professor.
present these the questions, please?
Yes.
Nimni?
So we have a few questions. First, I shall read out a question from Dr. Sabha Katak to our speakers. It would be good to receive feedback from speakers about the impacts on vulnerable groups, whether labor, both formal and informal sector workers, transgender, the poor, women, persons with disability, migrant populations, and their access to vaccines, as well as those without identity cards or papers. Not sure if South Asian countries' budgets have done enough for the vulnerable. Therefore, looking ahead, what possible steps can South Asian countries take with regard to social protection, economic and fiscal policies, and issues of violence against women, transgender, and other vulnerable groups? So this is his question to our speakers.
I would
Okay.
like to respond.
Yeah, we will take that issues at the end.
Yes. Then we have another question.
Yeah, please raise the other questions also.
Okay. The other question is from Dr. Shahid Hashmat. How SARC could have responded jointly to fight the COVID pandemic? Or should SARC be considered totally dead? Any possibility of reviving or revigorating SARC, at least to cooperate in situations of disaster management and disaster or crisis response? These are the questions we have. I think Dr. Madhubal, Professor Madhubal, she already raised a question.
Right.
So these are the questions.
Now, Ms. Saloni Singh, you want to raise some question?
Oh, yes. Yes, thank you very much, Professor. Actually, I would like to acknowledge and really congratulate all the speakers, even the participants who have given us the detailed overview about our situation and also very critical analysis on this. We have already heard some of the recommendations or way forward. But my question is not for the South Asia country, but as a think tank, regional think tank, as a regional organization, RCSS, what should be our role? How should we respond to these issues from our position? This is the question for everyone, especially for the RCSS. I think with this very rich discussion and deep analysis, we should come up with some strategies that we as a regional think tank can take and go ahead with. This is my, I don't know, you can take comment.
Thank you. Thank you, Ms. Saloni Singh.
Thank you.
Before we give the floor to our speakers, I would like to invite Professor, yes.
Professor Kiravel.
Yeah, just a minute. Professor Shashi. Yeah. Shashi.
May I speak something,
yes,
sir? May I speak something?
Yes,
so
please go ahead.
At the outset, I would like to thank the RCSS for inviting me as one of the participants and for today's webinar. And I thank all the speakers for their very excellent and comprehensive presentations. Sir, I have two brief comments to make over here. At the outset, I would like to say that we've been talking about SARC. So, yes, it is an institutional mechanism which can be revived at this opportunity. And though SARC has not done much work ahead, but there are two can be taken up over here. First, at the outset, it has given us an opportunity where India and Pakistan both can shed their differences and can jointly and cooperatively develop a regional health care system where a budget can be created. We have a lot of outside observers in SARC also. We can take their suggestions also, and fund that is created can help can jointly work for the entire South Asian countries. So apart from this, my question is also, I would like to ask Professor Munis Amar, sir, what is the reaction of the rural sections in Pakistan regarding this vaccine? And are the NGOs in Pakistan working up or doing any effort towards developing some sort of confidence in the rural sections for vaccine? And so thank you very much.
Thank you. Dr. Harish Chandra, you want to say something? Word?
Yes. To comment on policy incoherence in Sri Lanka from Dr. Richard Pereira.
Yes.
I think in Sri Lanka, according to the Quarantine Act drafted about 100 years ago, the DGHS should be the chief of this operation. But in Sri Lanka, you know, and Dr. Dihala Besi knows very well, the chief of operation is Army Commander. The entire Sri Lankan operation looks like a military operation rather than the operation pandemic operation. Therefore, some decisions are taken not based on the epidemiological data or the science of medicine, but on policies that governed by military rules and regulations. And also, the government have beliefs and faith on mythological treatments. And therefore, there are some policies taken, policies that such as importing vaccine and things were delayed because of those the stance of the government and other politicians and military operation. Therefore, the gross lack of coherence of policies in Sri Lanka in this operation. Thank you.
Thank you.
Yeah. Can I speak?
Yes. Yes, Dr. Yes, please. Go ahead.
With me?
Yes.
Right. No, I think thank you very much, Professor Kirella and your team for organizing this event, which is very time appropriate. There are common features here, as I gather. First of all, we are not dealing with homogeneous populations. They are in different levels of understanding and different roots of beliefs. They have different roots of belief systems and so many other differences. So it's very difficult to control or get everybody to focus on one aim because the complexity of behavior of people. The other thing is we all can be very wise in retrospect. You know, this could have been done better or something like that. We can always say like that. So, and we are talking about bygone wisdoms always. And at last, I would like to say that this is a conflict-prone situation. Any crisis is conflict-prone. That means there are diversities in opinion, diversities in belief systems, and so on. So it is a very complex situation. See, under these circumstances, Sri Lanka has done reasonably well, although our behavior of people could have been better. Thank you very much.
Okay. Okay, Dr. Anand Jayasinghe.
Yeah.
Now I would like to Tudor, yes. Yeah, floor is yours, Tudor.
Yes. Well, thank you very much. And thanks for having, encouraging this conversation. I think is a very important conversation to have at this juncture of the pandemic. I just want to make 2 or 3 points related to issues that were already presented by various, speakers. One issue was that, the nature of administration of this response, particularly in Sri Lanka. Already Dr. Harishchandra mentioned about the militarized nature of this response. That is perhaps an important concern, but also it's very top down. It's like decisions are made at the top without consulting the lower levels and like people at the bottom, including patients and people going through quarantine. We don't know what they feel, and their opinions are not consulted by anybody. And perhaps in the current situation of lockdown, it's difficult to facilitate it. But nevertheless, I feel that we should work towards a more inclusive approach. Inclusive in the sense, don't work in silos, but different parties come together. I feel that, as I think was also mentioned by another speaker earlier, perhaps we need to have a more inclusive approach, not just dominated by one medical system, but we have rich experience in this region, and so we need to create opportunities for various healthcare systems to, or curative systems to provide their services at this juncture. So we should not limit ourselves to just one system. And also with regard to the question that Dr. Harishchandra raised about mental health issues, I want to know his response regarding the role of religion, because at this moment, people can't go out and people are staying at home and they can't even go to temples or churches. So what implications it has for the mental health situation, I think it's very important to explore. I know people are also, they have resorted to online and Zoom type of religious experiences. So, we need to know what impact it has on mental health of different people. So these are a few quick observations I want to make for this session.
Professor Harishchandra, Dr. Harishchandra,
Yes.
quick response to what Professor Turasilla raised relating to the religion and psychology?
Yes. In fact, it has a place. But because of the nature of this psychiatric sequelae, especially with regard to anxiety, tension, fear, and uncertainty, those things can be, to some extent relieved. Believing on their belief system or particular person. Things like relaxation, therefore it has some place to some extent. But when it goes to pathological level, it needs medication and it needs long-term follow-up. However, when the some patients, those who are experiencing anxiety alone and uncertainty alone, they can be relieved and their resilience can be increased by their faith and their way of believing in their religion. Therefore, definitely it has a place for improving the resilience, but certainly not in the treatment of overt cases. Thank you.
Professor Muniz?
Yes, sir.
You have the chance to respond to.
Yeah, I just need to respond to, about the rural population in Pakistan. A question was raised. Rural population of Pakistan is not that exposed as far as pandemic is concerned. But it doesn't mean that 60%, around 55% of Pakistan's population lives in rural areas and villages and, farms. There are reports about, some of the people in villages who have been infected. But otherwise, the routine work is going on. The hot spots are particularly as far as the urban areas are concerned. But it doesn't mean that the rural population of Pakistan will not be infected. There has to be a strategy on the part of National Command and Operations Center, NCOC, to make sure that Pakistan's rural, life is not disturbed because of the pandemic or coronavirus. But so far, the immunity system, as far as the villages are concerned, such that to a large extent, the rural population has not been infected, but it may not be the case. The second thing about what Sabha Khatak mentioned, as far as the vulnerable segments of population of Pakistan, the informal workers and others, and people not having the CNIC, that is the national identity cards. I mean, this is true. That those who would like to get vaccines, there is 1161 something like that SMS message, and then they have to mention the national identity card. So if you don't have a CNIC, that then it cannot be done. So there is a problem. There's a crisis faced by the vulnerable segments of society. And Dr. Shahid Hashmat about SARC. Certainly, Nishal Pandey would agree with me that SARC is not dead, but certainly it is in limbo. So it's very unfortunate that it is limbo. Unfortunate that despite some virtual meetings, it has not been able. There is a disaster management mechanism which SARC agreed to, but they have not been able to activate it. Thank you.
Thank you. Dr. Nishal Pandey, are you there? Okay. Professor Karori Singh, you can respond.
Thank you, Professor Ghamini. Large number of questions have been raised, but I would like to keep them into four. The first is about the psychological. In India, certain hospitals are having tele-counseling. And in the COVID case, the cases of anxiety and depression are not the advanced stage cases. They are at the initial stage cases. I think the family members can be the greatest counselor if family members are counseling and helping them, giving them confidence and all that. And about the religion gives solace, definitely. But religion with obscurantism leads to some more problems as well. So the religion as a solace and the psychological counseling, two things are, I think, different. But it cannot be, tele-counseling cannot help. It can be person-to-person counseling, then person-to-person counseling can be more helpful. And the second about the civil society organizations. We all know the South Asian governments are not sympathetic toward the civil society organizations, which are getting funds from the foreign government countries. But in case of the local civil society organizations, they are doing very good job in regard to the COVID centers. They are providing food, medicine, helping the patients. They are doing marvelous job. I don't know about the Sri Lankan experience, but civil society organizations are doing good job, local civil society organizations. About the combination of indigenous and the allopathic medicine, I think Samarkand has rightly pointed out there is no medicine as such. COVID doesn't have any medicine. So the allopathic prescription code in the protocol, some medicines are included, then they are removed from the protocol, again they are included. So a sort of confusing situation is there. There is no medicine either in allopathy or Ayurveda. So whatever the medicine, that is the symptomatic treatment. But the Ayurvedic experience or the indigenous experience, it is somewhat experiential knowledge in the villages, in the village societies, over a long period of time. Through the experience, they are taking something that boosts the immunity in the physical sense, and in the psychological sense, they give confidence as well. So there can be combination. There is no contradiction since there is no medicine. So any treatment you take, sometimes in allopathy, they are giving placebo. Similarly, in Ayurveda, may not be effective, but it gives the confidence. So there can be combination if there is no treatment, both are relevant. About the SARC, quite often we in the South Asian countries, scholarly communities say the India-Pakistan relations is the biggest hurdle in the South Asian cooperation. I don't agree with them. This is not the only problem. What about NAFTA? NAFTA is not picking up. There is no problem like India, Pakistan in the NAFTA region. So the problem, whatever the understanding I do have of the international relations, the problem is the bigger countries, larger countries, they are not taking their regional organization with them while going to the international community. They emphasize on bilateral relations instead of the like European Union or the ASEAN. When India is going towards the Southeast Asia, it's the ASEAN plus India. It's not the ASEAN SARC initiative. So it's not the India-Pakistan problem. Of course, it is an important factor. Why there is no such thing in NAFTA? US is doing the same thing. US is also emphasizing the bilateral. So the SARC right at the moment is not picking up, but SARC can do better if it is revived. Of course, it already exists. I don't say it should be revived. If there is a South Asian solidarity and the civil society organization, people and the scholarly community should play some role. Because in the crisis situation, the solidarity is must. So whether it's the pandemic crisis or any calamity, the solidarity needs to be displayed, and that solidarity is not being displayed. That is the biggest problem. So I hope some kind of solidarity will be developed in the South Asian community, and South Asia will turn out as a community like the European Union. That is my wishful thinking. I don't know whether it will be possible or not. India and Pakistan relations can be improved, but that will not ensure the strength of the SAARC. That's all. Thank you, Professor Keriwala.
Thank you, Professor Karuri Singh. Dr. Nihal Abesinghe, you have the opportunity to respond.
Thank
Finally.
you. Thank you, Professor Kiravella, and very interesting comments, concepts, and observations were made following the discussion. So I think, I'm not going to talk about all, but very important points came actually about the mental health issues, and then the lack of coherence of policies, militarization, and top-down approach. So these are really these are important issues that we have taken more, because we were discussing about the public health system and the COVID pandemic response in the region. So I think based on that, maybe that there is a specific role for Ayurvedic or indigenous medicine. So we need to further study, or at least we need to have a healthy discussion what the real role could be. And also one important point came up, which is important for the RCSS. I think that the civil society contribution for the COVID control across South Asia, I think it's RCSS has, if possible, you have a better role to bring all the civil organization, across the Southeast Asia to discuss on this issue and see that what we can do, for the control of this, the pandemic in the next couple of months. So maybe, I don't know whether it is here or not, but there are so many things that which came up here we haven't touched sometimes, perhaps like the reaching vulnerable population, because some of us don't have that ability to reach as individuals. But I think RCSS, if you can really make some platform to discuss these things and highlight these things, and this is a good opportunity following this webinar, I think you should take up. Thank you very much for opportunity given for this participation in this webinar. Thank you very much, RCSS.
Thank you, Dr. Nihal Abesinghe. Now I would like to invite Professor Samat Dharmaratne, Head, Peradeniya University Community Medicine Department, to make concluding remarks. Professor Samat, are you there? Professor Samat Dharmaratne? Okay, now he's not available. Now I think we had a very good and the very rich the webinar discussion. Many points came up, and it is a issue that has many dimensions, and we have to continue this dialogue and discourse region-wide, because the challenge is so formidable. Therefore, I think this is just the beginning of the discourse. We have to continue. RCSS, with your support, we are ready to continue that. I'm not going to summarize the discussion, and we got also many messages, and the advices and the points to be carried out further in the future. With that note, I would like to invite Ms. Nimni Jayatilaka, Program Officer, Regional Center for Strategic Studies, who organized this webinar and who contacted you to make this possible, to make vote of thanks. Nimni,
Thank you, Professor. Good evening, everyone. It's my utmost privilege to deliver a vote of thanks on this occasion. So I, on behalf of the Regional Center for Strategic Studies, would like to sincerely thank all the speakers and participants for accepting our invitation to grace this occasion and for sharing with us your invaluable knowledge, findings, and opinions today. So a big thank you goes to Dr. Nihal Abesinghe for his efforts towards enlightening us with the Sri Lankan public health system. He explained the magnitude of the pandemic that Sri Lanka is facing right now and what kind of functions were more important in facing the pandemic and of course the lessons learned. Then, it is with deep sense of appreciation we thank Professor Karori Singh for his insightful explanation of the challenges encountered by the public healthcare system in India in the current context of the pandemic. Further, we are grateful to Dr. Nishal Pandey and Professor Munis Ahmad, two long-standing friends of RCSS, for their interesting views on the public healthcare systems in their respective countries, and for giving an excellent coverage on the interventions of Nepal and Pakistan during the COVID-19 pandemic. So I cannot thank enough all of you who participated, who accepted our invitations, who participated and contributed in today's discussion, providing versatile insight on this topic. Finally, an event like this cannot happen overnight. The wheel starts rolling weeks ago. It requires planning and a bird's eye for details. Hence, I would like to acknowledge my gratitude to the Executive Director of RCSS, Professor Gamini Kiravalla, for his extensive encouragement, constant guidance, and overall supervision throughout this process in organizing the webinar. Last but not the least, I would like to extend my sincere thanks to our program officers, Ayodhya and Shavini, and our administrative officer, Amali, who worked collectively to make this webinar a success. Thank you everyone for your contribution today. Hope to see you in the future with more webinars. Thank you.
Thank you.
Thank you all. Thank you.
Thank you, Professor Kiravalla.
Right, thank you.
Thank you very much.
Thank you. Thank you. Bye.
Thank you,
Thank
sir.
you very much.
Thank you.
Thank you.
Thank you, Namesh.
Thank
Yes, nice to see you, Nelum.
Nice to see you, sir.
Yes.
Thank you very much for given this opportunity for me
Well,
also.
Yeah, I saw you after a long time.
Yeah, me too, sir. It is pleasure to see you.
Right.
Thank you.
I had the opportunity of visiting RCSS a decade back.
Okay. You can visit again when COVID clouds disappeared from the sky.
Very true, very true.
Yes.
Thank you so much, sir. It was a great privilege.
Yes. Thank you.